Hi, this is Brian Kim. I want to share with you this case of a patient who has referred to me for a dislocated lens. This lens is in the sulcus and it's found to be quite a bit dislocated inferiorly. What I didn't realize at the time was that this is a PMMA optic IOL. And you're going to see me breaking my scissors, unfortunately, and I'll have to employ a scleral tunnel technique to take this lens out, followed by my modified Yamane technique. So you can see this is the lens and how severely dislocated it is. And it's amazing. You can hardly see any capsular bag in this situation. I'm often just surprised on how the surgeon put the lens in and got away with it. And second, the fact that the lens implant hasn't dislocated until now. So you can see I dried the surface of the eye thoroughly with the wax cell sponge. And then I use a 25 gauge cannula with the tip inked. And I mark the limbus on the right side and then the left side, making sure I'm 180 degrees apart. And this is a fixed caliper by Epsilon. I have no financial interests. And the first mark is 2.5 millimeters, indenting in radial fashion from that first mark, and then 2 millimeters adjacent. Again, inking those indentations on the right side and doing the same thing on the left side in similar fashion. You have to make sure it's completely dry. And the wax cell is very important for this. Again, 2.5 millimeters posterior to the limbus, indenting the sclera. You get that little indentation mark there. And then 2 millimeters adjacent, indenting again, making sure it's nice and dry. By having it nice and dry, you're able to get these really nice, distinct marks. Again, precise and distinct marks means a precise scleral needle placement. Using the cotton tip to control the eye, I'm indenting about 3.5 millimeters posterior to the limbus. And then switching to the needle, I'm going to tunnel about 3 millimeters to that mark, tunneling, making sure I'm nice and flat to the sclera, and then diving down perpendicular, and then withdrawing the needle in the cannula stage. And hopefully the sclerotomy will self-seal, and you know this because the cannula is sitting slightly sideways. Making my incisions first on the right side and then the left side, which will help me explant this lens. This is a contralateral limbal incision to explant the leading haptic. And this is the incision for the 22 gauge thin-walled AC maintainer. This is intracameral epinephrine, and then some dispersive viscoelastic to coat the corneal endothelium. This is a 3 millimeter blade, make a vertical groove, tunnel, and then I enter. Using 2 forceps, grasping the lens, lifting the leading haptic up into the anterior chamber, making sure it's secure. I hold it, grasp the optic, and then pop that trailing haptic up into the anterior chamber. So I'm holding it with the serrated forceps in my left hand so that I can quickly transition to the scissors. And lo and behold, as I try to cut it, it doesn't cut. And I thought to myself, this has blue haptics. This should be an acrylic lens, but obviously I don't know all the different lenses that have been manufactured around the world or in the country. And here I keep cutting, and I broke my scissors. So I should have known better. I should have just quit while I was ahead. So I go ahead and place a traction suture in the limbus, turn the eye away from me, and I'm going to have to make a scleral incision, a scleral tunnel, to get this lens piece out. Start my peritomy. You don't really have to make a huge scleral tunnel. Again, it has to just be around 6 millimeters to match the optic. So I do a conj cut down, do a little bit of cautery, use my crescent blade, holding the limbus, and this is where doing anterior segment surgery, a variety of techniques, including M6 cases, even trabs when I used to do them back in the day. That skill will translate well to this situation. When you have to make a scleral tunnel, you know how to wiggle the crescent blade. Again, I'm by no means an expert at M6, but these are kind of some fundamental techniques. You want to do that wiggle, and the M6 surgeons are masters at doing this, and they do this really well, and well-executed tunnels as well as very efficiently performed. But obviously I'm taking my time. I want to make sure I'm nice and low. I don't want to make the tunnel too thin. I don't want to have a unstable tunnel. You can see I broke the traction suture, but at that point I figured I'm already mostly done with the tunnel, so it's not a big deal. I'm trying to enter with the crescent blade. I'm not able to do so. I switched to my paracentesis blade, being mindful to gape the incision so I don't create another cut through the cornea. Once I enter, I widen the incision on each side. And then now I'm able to take this lens out in one piece, grasping the optic and then grasping the trailing haptic, pulling it through the incision, switching hands. And then I'll go ahead and reach for the optic. Lift the roof of the scleral tunnel, and the lens comes right out. Okay, looks pretty good. Just checking the wound for vitreous. Again, I don't pull away with the Wexel sponge. I just need that sponge there to absorb the fluid. And again, I'm just cutting along. I don't really see much vitreous, but there is a little bit. And so that's why I place the Wexel and then just cut. I don't yank to see if there's anything there. I just hold it there and I cut. And I'm just trying to get all that excess fluid and viscoelastic and, if there's a little bit of vitreous, just get all that matter out of there. So just keep cutting, 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 and then pushing some dispersive viscoelastic through the sclerotomy. So if there is any vitreous, I push it back into the eye and then coming through a different angle, pushing some more viscoelastic and trying to sweep that out. So again, I don't really see much vitreous there. That's mostly viscoelastic. And then I close the sclerotomy with 8-0 vicryl suture. And I'm going to place 3 sutures just to be on the safe side, nice and tight. Obviously, this is accelerated just for time purposes. And then I close the conjunctiva with the same suture. A little bit annoying, have to do all this work, but this was necessary for this case. Placing the 22 gauge thin-walled AC maintainer. And then performing pars plana vitrectomy now. Again, in the anterior vitreous space, sub-iris plane and anterior chamber, I don't really see any vitreous. Clearly, just below that plane, you could see some vitreous moving around. But again, that's really deeper in the deeper anterior vitreous space. Most of the stuff in the anterior chamber really just looks like viscoelastic, the viscoelastic that I pushed earlier. Here I'm injecting some intracameral triamcinolone to look for any more potential vitreous. And again, there is some viscoelastic in there, so it does act like a barrier. But again, not obvious, not much vitreous there. 25 gauge needle, bending it so that the bevel is facing to the right, making sure it's mounted on a 1 cc syringe with BSS and push BSS through. This is a right side needle, bending the needle 9 millimeters from the tip, making sure the bevel faces towards the main incision. And on the left side, same thing, again, mounted on a 1 cc syringe full of BSS, push the BSS through, and then bending the needle at the hub, making sure that the bevel faces the contralateral limbal incision. This is a cartridge, the emerald cartridge for the Sensor AR40 lens, pushing cohesive viscoelastic through the barrel as well as on the platform. This is the AR40 lens. Go ahead and place it into the platform, making sure it's seated. And you can do the little wiggle, which confirms it's seated. Bringing the wings together, making sure that the optic bends backwards. The leading haptic comes through the barrel and straightens out, and the trailing haptic goes outside to the back end. Placing the cartridge into the injector, making sure that the trailing haptic is up. In this case, it's not, so I use a cannula to pop it up. You saw that? So that's the position you want. It's nice and up, away from the plunger, advance the plunger, and then I'm ready to go. This is a 25 gauge needle, contra-incisionally. You can see how bent it is. I make sure the bevels are facing each other. As the lens is advanced, I dock the haptic on the bevel of the needle. As the lens is advanced, I pull the needle out and the haptic comes out. Advance the optic myself. Sweeping the trailing haptic to the right. As the lens unfolds, I push dispersive viscoelastic between the lens and the cornea, making sure that the cornea is protected, and also to push the optic back. Sometimes the chamber maintainer will catch on the edge of the optic. Holding the trocar, I stab the conjunctiva and sclera with the needle. At the first mark, I flatten out, stay nice and flat, tunnel to the second mark. You can see my needle, and then I dive down towards the optic nerve, and then I rotate. I make sure that the leading haptic is pulled further out so the optic is pushed away. This gives me a lot more room to work with the trailing haptic. I slide the trailing haptic into the incision, sliding it sideways, minimizing any tension on the haptic. These are my smooth microforceps. I dock the haptic on the bevel of the needle. A few pushes is all I need, and then I'm ready. Disengaging the needle from the syringe and laying it down. And then this is the, again, smooth microforceps. I internalize the leading haptic, laying it into the angle. And then now we're going to work on the left side. I'm holding the contralateral limbal incision with forceps. Again, I'm going to stab at the first mark through the conjunctiva and sclera. Once I stab, I flatten out and I tunnel 2 millimeters to the other mark. And then I dive down toward the nerve, rotate the needle so I can see it, grasping the leading haptic with the smooth forceps, docking the haptic on the bevel of the needle, re-grasping, pushing it. 2 pushes is all you need, and I'm in. Withdraw both needles slightly so that the optic haptic junction is not tugged on too tightly. Pull the left side needle towards me, and then making sure I minimize and limit how much haptic comes out, which minimizes stress on the contralateral optic haptic junction. Drying the surface with a wax cell sponge. Cauterizing the tip to create a small bulb. And that's that. You can see how flat the haptic is sitting, which means I do not have a flagpole sign. A flagpole sign means you have poor scleral support for the haptic, and therefore the lens is going to be tilted or, again, poor technique. Pull the right side needle away, and as I pull it away, I grasp the haptic and limit how much of that haptic comes out, again, to limit any tension on the contralateral optic haptic junction. Dry the haptic with a wax cell sponge, and then cauterizing the tip, creating a flange. Pushing the haptics flush to the sclera, making sure the haptic bulb is nice and flush and pushed down. Reapproximating conjunctiva, closing the main incision with the tenon suture, performing the surgical PI. Again, I have a special setting for that, which has a low cut rate. Again, don't place the cutter all the way into the angle. You want to place it where you normally would place your laser PI. You want to be able to visualize it so it's not in the periphery, and turn the port down, grab it with some aspiration, cut, and then you're done. Just a few cuts. Performing limbal vitrectomy and then switch to cortex mode to remove the viscoelastic. I go back to the pars plana and perform some more vitrectomy. Again, all of this is just to ensure everything looks good. Hydrating my incisions. Obviously, I have my AC maintainer, which will make sure I have a nice firm globe. Pushing and pulsing some BSS into the anterior chamber to remove the viscoelastic that's coating the corneal endothelium. You want to irrigate that viscoelastic out to minimize pressure spike postoperatively. And again, so far it looks really good. Well-centered lens. Really happy with the result. Really bummed that I broke my scissors. Those are expensive. Grasping the trocar, pulling it out, and as I pull it out, I massage the sclerotomy, making sure it's not leaking. Turn on infusion, and fortunately, there's no leakage, so that's great. Pull out the 22 gauge AC maintainer, hydrate my incisions, and that's going to be the end of the case. So again, this patient was referred for dislocated, again, I'm realized now, a PMMA IOL. I was able to pull that lens into the anterior chamber. When I tried to cut it, I broke my scissors. So then we switched gears, put a traction suture in, peritomy, cautery, and then using a crescent blade, I did a scleral tunnel technique. again, which is similar to M6. So it's always good to learn these techniques. Did the scleral tunnel, was able to widen the incision, pull the lens out in one piece, close the incision, and then perform the Yamane technique using the Scleral AR40 lens, externalizing the leading haptic through a contralateral limbal incision with a passive 25 gauge needle docking technique, docking the haptic on the needle, and then performing my modified Yamane technique. By externalizing the leading haptic, you're able to push the optic away, and you can see how easy I was able to cannulate the right side needle with the trailing haptic because access is so much better, and I'm able to really execute the surgery with minimal traction on the haptics. I'm able to pull the leading haptic in the anterior chamber, execute it the same way, but the left side needle, since it's away from me, it's ergonomically much easier to cannulate the leading haptic through the left side needle. And you can see, as I always do, I always dock the haptic on the bevel needle. Once you dock it there, you can actually re-grab the haptic. And so that's another way of stabilizing that haptic, docking and then advancing the haptic. I was able to pull each needle out just a little bit, limiting how much haptic comes out, which limits how much tension is on the optic haptic junction contralaterally, creating the small bulb. Again, you noticed and confirmed that there is no flagpole sign. When there's no flagpole sign, the patients usually have a very good scleral support, again, simulating the intended lens position as if you were placing the lens in the capsular bag. This patient, even though there was a suture in the eye, post-op day 1, the cornea was crystal clear and his visual acuity was 20/50 uncorrected. So 20/50 uncorrected with a suture, clear cornea, and this patient has done very well. So I hope this was helpful to you, and I thank you for your attention.